السلام عليكم. اليوم نكمل المحاضرة الثانية اللي تتكلم عن ال bleeding disorders. Our lecture today our lecture today bleeding disorders related to secondary hemostasis. I am أستاذ مساعد دكتور بسام محمد حميد. Lecture objectives. At the end of this lecture, we will hope that students will be able to use laboratory investigation for hemophilia diagnosis, use laboratory investigation for Wöhlbrand disease, and use laboratory investigation for disseminated intravascular coagulation. Hemophilia word in Latin means hemo, blood, philia, love, means love to bleed. Hemophilia is a bleeding tendency for the patient. In the last lecture, we talked about the principle of coagulation cascade and the role of platelet in hemostasis and in disease. In this lecture, we will talk about disorders in the secondary hemostasis, mainly selected topics in coagulation disorders. First of these is hemophilia A. Hemophilia A is the most common type of hereditary clotting factor deficiency, in which there is a deficiency in factor 8 factor. There is a sex-linked gene. Factor 8 gene usually rests on chromosome X, and this disease is a sex-linked disease and present mainly in males, as males have only one X chromosome. So when they have the defective genes, they will have the disease. Family history is very important. Despite that, there's about 1/3 of patients that have negative family history because the mutation occur during fertilization. As you remember from the last sessions, factor 8 has a role, it is a cofactor for factor 9 in activation factor 10. It is a part of the intrinsic coagulation system. Patient if have defect in factor 8, there will be reduced activity in the production of factor 10, and this lead to lower thrombin generation. And as we said in the last lecture, thrombin generation is a key role in generation of fibrin, which will cement the primary hemostasis and forms a solid hemostatic block. So when there is no factor 8, no factor 10 enough, no thrombin time enough, and there is a defect in fibrin generation, so patient will have more likely to have a bleeding tendency. How is the patient present? Usually, infant may develop profuse circumcision hemorrhage. Circumcision is related to Muslim countries. احنا بلدنا بالعراق نسميه طهور، اللي هو يصير عادة أول أيام النيوناتال period. Patient usually develop profuse post-circumcision hemorrhage or joint and soft tissue bleeding into joint. As you remember from the last session, defect in secondary hemostasis present with usually deep bleeding into joints, bleeding into muscles, internal GIT bleeding sometimes. So this is the same picture. In this, we'll have patient may have bleeding after circumcision or bleeding into the knees when the child start to crawl. من يبدأ الطفل يزحف على الأرض يصير عنده bruises، يصير عنده bleeding بالelbows بالknees، اللي هي هاي ال features of activity. Recurrent painful hemoarthrosis and muscle hematoma dominate the clinical picture. Facial hemoarthrosis bleeding into the joint, muscle hematoma bleeding into muscle compartment, and patient may have a joint deformity or disability. Patient may present with prolonged bleeding after dental extractions. Uh, in a rare condition, the patient may develop hematuria, that is to say, bleeding into urine, gastrointestinal hemorrhage as melena, sometimes with obstruction resulting from the intramucosal bleeding. This means that bleeding into the GIT mucosa may enlarge and block the GIT, and patient may present, especially in children, as intestinal obstruction. As you see in this illustration, important site for bleeding into the joint called hemoarthrosis. If a chronic and repeated joint, they may have a joint deformity. Bleeding into muscles may cause ischemia to the muscles because of compression, ischemia to the muscles and scarring of muscles, and may lead to compression of nerves because these muscles, what is called, if you remember from anatomy, what is called compartment syndromes, all muscles enveloped in fascia and bleeding into muscles, there is no space for the blood, so will compress blood vessels and nerves. Compressing nerves lead to uh, de-innervation and muscle atrophy, and compression to blood vessels lead to ischemia and scarring. Sometimes the bleeding may present in abnormal site like retroperitoneal bleeding or intracranial bleeding, which is very severe and life-threatening condition. How we diagnose hemophilia A? As we said, hemophilia A uh, is, is a factor A deficiency. So what we expect in the laboratory investigations, or pathway involved in factor 8 will be prolonged. So we have activated partial thromboplasmin time. PTT will be prolonged. On the other hand, PT, which is mainly measures the extrinsic pathway, is usually normal. When we measure a factor 8, it will be markedly decreased. Platelet function usually normal, as there is no abnormality in prothrombin time. So, patient present um, with early life bleeding tendency, and we do PTT. We have three differential diagnoses. Mainly, we have three common inherited disease. These are hemophilia A, that is to say, factor 8 deficiency; hemophilia B, that is factor 9 deficiency, or called Christmas disease; or a von Brandt disease. As a von Brandt, it is uh, a factor that protect factor 8 from degradation. So when we have prolonged partial thromboplasmin time PTT, we must measure factor 8, factor 9, and von Brandt factor. In this condition, in hemophilia A, factor 8 will be low, factor 9 will be normal, and von Brandt factor will be low. This picture shows joint deformity in a patient with hemophilia A. As you see, deformed knee joint, and as you see in the picture, there is contraction, there is muscle scarring and fibrosis. This lead to contraction of muscles. Here we see as there is muscle atrophy, this leg is better, and this is spasm because of repeated bleeding and hematoma affecting the thigh muscles. This is classically present in patient poorly treated hemophilic patients. The second disease that is closely mimic and goes hand with hemophilia A, factor 9 deficiency, what is called hemophilia B or Christmas disease. Hemophilia B also inherited disease due to factor 8 deficiency or mutations with clinical features identical to hemophilia A. The only difference is that hemophilia B is less common, than hemophilia A. So when we said we have almost the same clinical features, PTT will be prolonged, prothrombin time PT will be normal, platelet count normal, platelet function normal. So we have PTT prolonged, we must measure factor 8, 9, and Willebrand factor, and we will see that factor 8 normal, Willebrand factor normal, and factor 9 will be reduced. The, the third inherited disease is Willebrand disease. As we said from the last sessions, Willebrand have dual functions in hemostasis. First, it's involved in platelet adhesions. So that is to say, bridges the gap between subendothelial collagen and the platelet. Willebrand factor will bridge the space between subendothelial collagen and the platelet. So it has a role in platelet adhesion. Second, Willebrand factor is a carrier for factor 8, so prevent degradations. So when we have a Willebrand disease or Willebrand disease, usually the first difference is usually autosomal dominant. That is to say, not X-linked, differ from both hemophilia A and B. Autosomal dominant are usually more common in females. It affects primary hemostasis and secondary hemostasis. It affects primary hemostasis in a way that is usually related to abnormal platelet functions. Platelets in Willebrand disease unable to adhere properly to the site of injury. So it will present with abnormal platelet function and will affect primary hemostasis. Also, it will affect factor 8, when there is a Willebrand factor deficiency, factor 8 will be cleared from the circulation. So we will have a factor 8 deficiency. So it will affect both dual primary hemostasis and secondary hemostasis. As a consequence of that, bleeding clinical features of Willebrand disease is slightly different. It presents more common in female, autosomal dominant, so it is more common than hemophilia. Also present with mixed type of bleeding, that is to say, bleeding due to defect in primary hemostasis and the bleeding because of secondary hemostasis. Patient may present with purpura, epistaxis, menorrhagia, bleeding from mucosal membranes. Also present from, in severe condition, may present with hemoarthrosis, muscle hematoma, deep bleeding, similar to hemophilic patient. Laboratory finding platelet function test is usually abnormal. Sorry. Platelet function is usually used to measure platelet function instead of bleeding time that we talked about in the last session. So usually platelet function test is usually abnormal because there is a defect in the platelet function. Second, factor 8 will be low, and this is expected, as we said, that Willebrand factor is a carrier for factor 8. So when there is no Willebrand factor, factor 8 will be degraded and the level will be low. Activated partial thromboplastin time APTT is usually prolonged. Willebrand factor usually low. When we do platelet aggregation, there is a test called the platelet aggregometer in which we measure platelet adhesion and aggregation abnormalities usually used in the diagnosis of functional platelet disorders. So when we do this test for a patient suffering from Willebrand disease, there will be abnormal aggregation in the presence of ristocytine. Aggregation to other agents, adenosine, diphosphate, thrombin, and adrenaline is usually normal. Collagen binding function, usually not common test, but as we said, if one brand will bridge platelet adhesion to subendothelial collagen, usually will be reduced. Platelet count, usually normal. So we are here covering the most important inherited coagulation factors that mainly uh, occurs in coagulation cascade or secondary haemostasis. Now we will move to disseminated intravascular coagulation. Uh, there are many acquired conditions that lead to bleeding tendency and defect in secondary hemostasis. For example, liver disease, as most coagulation factors manufactured and synthesized in the liver. So, a defect in the liver disease, chronic liver disease, will lead to abnormal bleeding tendencies. Also, malabsorptions, vitamin K deficiency, all these will lead to reduced function of coagulation factors, mainly factor 10, 9, 7, and 2. But here we will talk only about disseminated intravascular coagulation for two reasons. Mainly because it is a very common condition that we may see in pediatric and obstetric conditions, in surgery, in medicine, and it is a life-threatening condition. So in this lecture and for your grade, we will only focus for disseminated intravascular coagulation. As its name implies, disseminated intravascular coagulation. Disseminated, that is to say, widespread intravascular coagulation, that is to say, thrombosis in the blood vascular system without injury. In normal hemostasis, there is endothelial injury that lead to thrombosis and clot formation. In DIC, there is disseminated, inappropriate, without injury, intravascular coagulation and thrombosis. So the definition of disseminated intravascular coagulation is widespread, inappropriate intravascular deposition of fibrin with consumption of two things, coagulation factors and the platelet. This occurs due to many disorders that lead to increase of procoagulant materials, mainly tissue factor, into the circulation, and we will explain this a little in depth. So, uh, widespread release of procoagulant materials like tissue factors in the circulation, this will lead to widespread endothelial injury and induce primary and secondary hemostasis. Clinical features of disseminated intravascular coagulation may be in two forms, either severe hemorrhage because of consumption of coagulation and platelet, and as you know already that platelet and coagulation factors are the main pillars for hemostasis. So when these two materials consumed, the patient will have severe bleeding. And paradoxically, the patient may be suffer because of thrombosis, because of platelet activation and thrombosis, a certain vascular system that patient may present with infarction and severe and ischemia. So patient may develop either a bleeding tendency or infarction and thrombosis or a mixture of both. Most common presentation usually bleeding tendency, about 90%. A lesser common presentation is infarction, ischemia, and tissue infections. Pathogenesis. Pathogenesis, that is to say, how the disease evolved. Pathogenesis explains the relationship from the cause to the sign and symptoms and pathological findings. The term pathogenesis means the generation of the disease, how the disease is generated, how the disease is evolved, how the cause of the disease will manifest its manifest. So we'll talk few words about pathogenesis of disseminated intravascular coagulation. The key event in this condition, DIC, is increased activity of thrombin. And as you remember from the last session, we talk about the role of thrombin in generation and activation of coagulation factors. So we have also here thrombin generation, improper thrombin generation that cannot be neutralized by anticoagulant materials like antithrombin or protein S or protein C. So the first event is there is a generation of thrombin. Thrombin generation results usually from tissue factor. Tissue factor usually expressed and enveloped below endothelial cells. In DIC, tissue factors may release into the circulation either from damaged tissue, so damaged tissue will release tissue factor into circulation, huge amount of tissue factor because of extensive tissue damage, like in septicemia, like in multiple trauma patient, like in severe burn patient. All these will cause extensive tissue damage, and these damaged tissue will release tissue factor. Also, sometimes tissue factor present on tumor cells, and this tumor cells will upregulate and increase expression of tissue factors or circulating monocytes in inflammatory conditions. These all lead to increased expression of tissue factors. Many factors lead to increased expression of tissue factors. These will lead to improper generation of thrombin. After generation of a thrombin, fibrin will be formed. Fibrin, thrombin, by action of thrombin is to change fibrinogen, which is insoluble materials, into, change fibrinogen, which is soluble materials, into fibrin, which is insoluble material. Fibrin in the microcirculation, microcirculation will be deposited on the endothelial cells. So fibrin, as a result of activation of thrombin, will be deposited on the endothelial cells and contribute to the coagulation factors. After any coagulation, any thrombotic event, there is a fibrinolysis. In normal hemostasis, after primary hemostatic plaque and secondary hemostatic plaque occur, this secondary hemostatic plaque in normal, let's flash back to last session, solid thrombosis is usually localized. That's to say, confined to the site of injury, confined to the site of endothelial injury. And this is localized thrombosis is monitored by fibrinolysis. After thrombosis is formed and fibrin deposition, the body will initiate a process of fibrinolysis, that is to say, dissolving extra fibrin strand and cutting down degradation fibrin, and so there will be a localized thrombus. In DIC, this fibrinolysis, because of widespread coagulation, lead to generation of huge amount of what is called fibrin degradation product that will interfere with the normal coagulation systems and will augment, that is to say, increase coagulation defect. All these processes lead to depletions of fibrinogen and all coagulation factors, and this widespread platelet aggregation lead to thrombocytopenia. So bleeding is a major manifestation of DIC because of thrombocytopenia and coagulation defects. This is a summary. This diagram from Robin's pathological basis of disease. It summarizes the pathogenesis of disseminated intravascular lesion. When we have a massive tissue destruction, like in a trauma or burn, we have obstetric condition، يعني حالات الأمراض النسائية، ويبقى جزء من البلاسنتا product of placenta. Placenta is rich of tissue factors. When there is septicemia and activation of inflammatory response and monocyte activations, and when there is endothelial cell injury, all these lead to the activation of tissue factor. Endothelial cell injury will induce platelet aggregations, and platelet aggregation activation will cause activation of primary hemostasis, and tissue factor release lead to secondary hemostatic effect. These both will cause widespread microvascular thrombosis. So the end result of these multiple etiologies will lead to the generation of widespread microvascular thrombosis. What will happen here? This thrombotic event will block the vascular system, lead what is called microangiopathic hemolytic anemia. That is to say, hemolytic anemia, hemolysis of RBC, is due to fibrin strand deposit in the microcirculation. Microangiopathic hemolytic anemia means there is RBC hemolysis because as the RBC pass in the microcirculation, it will be shattered and scissored. راح تقطع بسبب الفايبرين strand and there will be hemolysis. Vascular occlusion also will lead tissue ischemia. As expected, blood vessels will be plugged, so there is no blood, no oxygen, and vascular ischemia. Two other things will be occurs: consumption of coagulation factors and platelet because of extensive inappropriate thrombosis. This lead to bleeding and activation of plasmin. Plasmin is one component of fibrinolytic pathway, so will induce fibrinolysis and will catalyze coagulation factors. With this will add more, augment more to the bleeding, and fibrin split product end results of this whole story of thrombosis that will be lead to fibrin and fibrinolysis degradation of fibrin will will increase fibrin degradation product. With this will cause inhibition of a thrombin, platelet aggregation, and fibrin polymerization. This diagram is very important. You need to go through it and read the text because it is important subject to deal with. So now we are talking about the causes of disseminated intravascular coagulation. Yeah, I see. First, infection. Infection can cause severe disseminated intravascular coagulation because of the septicemia, for example, causing severe inflammatory response and increased tissue factor expression by neutrophil and by monocyte, and this increased tissue factor will induce disseminated intravascular coagulation. In addition, certain types of bacteria cause materials may carry materials similar to tissue factor action in their bacterial wall. So these bacteria may induce disseminated intravascular coagulations. Malignancies, especially adenocarcinoma, uh, as you may cross it in previous sessions about neoplasia. Malignancy, especially adenocarcinoma, may express tissue factor into the circulation and induce disseminated intravascular coagulation. Obstetric complication like intrafetal death, preeclampsia, intrauterine hemorrhage, placental abruption, all these there is abnormality in the placenta and placenta rich in tissue factor. These tissue factors will be secreted into the maternal circulation, and in maternal circulation they will induce coagulation cascade and lead to improper thrombin generation and formation of disseminated intravascular coagulation. Hypersensitivity reaction, especially if anaphylaxis or abnormal wrong blood transfusion. So hypersensitivity reaction will lead lysis to RBC or allergic reaction and induce tissue factor activity. Widespread tissue damage, like in multiple trauma patient from blast, from road traffic accident, from falling from high building, all these will lead to extensive tissue damage, severe burn. All these lead to extensive tissue damage, and this will release tissue factor and cause disseminated miscellaneous condition like for example like snake venom. الأفاعي سم الأفاعي have a thrombin-like materials in their venom بس مالتهم يكون عندهم مادة تشبه الثرومبين, so induced DIC conditions. Laboratory diagnosis of disseminated intravascular coagulation. As we expect, a bleeding time will be prolonged as patients usually have thrombocytopenia. So as we said in the previous lecture, bleeding time usually measure primary hemostasis, and we have defect in primary hemostasis as there's no platelet. Platelet count usually decreased and low. Prothrombin time and partial thromboplastin both prolonged because there is consumption of coagulation factors. Almost all coagulation factors will be consumed, so will be prolonged PT and PTT. D-dimer will be increased. D-dimer is a part of fibrin degradation product, and as we explained, there is extensive fibrinolysis in DIC, so we'll have high D-dimer, and fibrinogen will be markedly reduced because it will be consumed by the hyperactive thrombin, so it will change fibrinogen into fibrin. So in measure fibrin, it will be reduced. This picture in patient suffering from what is called microangiopathy. As we said, that when there is DIC, there will be fibrin strand in the microcirculation. So these fibrin strand will act like scissors for the RC, as you see in this blood film. First, notice there is no platelet. There's no platelet in this blood film. There is what is called schistocyte RBC. RBC fragmented and cutted. This RBC, this. These are called what is called RBC, red blood cells fragmentation syndrome. Red blood cells fragmentation syndrome occur in more than one condition. One of them is uh, DIC. This is large polychromatic cells. This is nucleated RBC. These are mainly called these large cells, oval, called reticulocyte. Reticulocyte means there is a hemolysis of RBC, so more and more mature red blood cells will appear on circulation. So combination of reticulocytes and thrombocytopenia, low platelet, and red blood cell fragmentation. The diagnosis is microangiopathic hemolytic anemia. In this picture, we show different presentation of disseminated intravascular coagulation. In the upper view, you see there is ecchymosis and hemorrhage beneath soft tissue and skin. This is a hemorrhagic manifestation of disseminated intravascular coagulation. While in the lower picture, as you see, there is a blue discoloration of both feet because of there is occlusion of the vascular system, there is a thrombosis, and there is ischemia, and the blood not reaching enough to the peripheral side. So DIC can present with hemorrhagic manifestation or present with ischemia. Okay, we reach our last slide. I hope you so you do so a sort of self-assessment. You by reviewing the previous two sessions. What are the screening tests for bleeding tendency? This is mainly in the first session. What are the pattern of presentation in a bleeding tendency? We said there are two patterns, either mucocutaneous bleeding or deep bleeding, and we said mucocutaneous bleeding related to defect in primary hemostasis, while deep bleeding, joint bleeding related to coagulation disorders. I like you to review and focus mainly on laboratory diagnosis of idiopathic thrombocytopenic purpura, hemophilia A, hemophilia B, Willebrand disease, and DIC. And it's lovely to go again and review pathogenesis of uh, disseminated intravascular coagulation. Thank you. I hope you find this lecture is useful. I will send you a review video and maybe a link for YouTube for this lecture for better access. Thank you and have a good day.